So I'm delighted to introduce Bethan Cowley. Bethan is the lead nurse for the ICC service at the Brompton. And Bethan's going to talk to us about phenotypes during the teenage years and the importance of transition. Thank you, Bethan.
Thank you, Nora. Can everyone see my screen? It's a little bit unnerving because I can't see anyone else. I'll take that as a yes then. So thank you, Nora, and thank you, AICC, for inviting me to speak today. Now, I kind of have a confession. I've decided to drop the phenotypes and just talk about transition. I hope you like the font. My teenagers thought it was a bit cringe, but I liked it. So I've dropped phenotypes for a good reason, because by the end of my talk, I really want the message to hammer home about the importance of transition. And actually, when it comes to transition, phenotype really shouldn't matter, because irrespective of why a young person's in the ICC service, any ICC service, they should all have some sort of transitional care, be they mild phenotype, severe phenotype, or even a familial screen. I also want to argue the case that actually dedicated ICC transition is warranted and give some ideas or some considerations to what makes an effective ICC transition service. It would be remiss of me not to discuss young people and the digital care, and also just to finish off with a few future thoughts and a few possibilities. So the process of going from adolescence to young adulthood is fraught with so much change, be it psychosocial, physical, cognitive, and for the majority of us, it's not that bad. I mean, you know, at worst, a few bad haircuts, your sister reading your smash hits magazine before you do. But unfortunately, for a large proportion of young people in the UK, it's not so simple. As you can see there, 1 in 7 young people aged between 11 and 15 have some sort of long-term illness, chronic condition or disability. But the good news is that with medical advances, we are seeing a lot of young people now living to adulthood, and that includes 90% of children with congenital heart disease, and now we can expect people with cystic fibrosis to live into their 50s. But what we also know is that more children are moving in from child to adult services, and on the left there you can see some key areas of adolescent development, and it's quite multifaceted. So why is transition important? Well, the process from moving from paediatric to adult services is highly linked with a deterioration in health, especially for those with chronic conditions. Now, if you look at, again, the key areas of adolescent development there on the right, and you add in a chronic illness, or in the case of our ICC patients, a risk of chronic illness, maybe a sick relative who has an ICC, or maybe a familial death, or God forbid all three, which isn't unusual in ICC care, then we're heading for a lot of problems. And if transition isn't implemented and carried out appropriately, we know that these young people are at increased risk of non-adherence and compliance to treatments and disengagement with health services and healthcare professionals. And I think you can all sit there at home and reel off a few young people that you know fit that bill. And sadly, the consequences of this, like it is with most people, is that there are serious physical, clinical, and mortality outcomes associated with that, including social outcomes and educational outcomes. So transition. And this is where a lot of people get confused. It's not transfer. Transition is a process, and it can start from the age of 12 to age 22. A lot of people get maybe a bit confused about that latter end of the time scale, but it is, by definition, transition does range from the age of 12 to 22. And it shouldn't be seen as a transfer. Transfer indicates a single event, but transition is a process, and it's defined as the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-orientated healthcare systems. Breathe. So again, I want to emphasize it's not a transfer. Study looking at transition in diabetes showed that 20% of what was considered transition was just a letter to adult services. And I think calling it a passport doesn't make it any different from a letter. It has to be a dedicated process with the aim of being able to support young people in health education and reaching their full potential in all aspects of their life. Unfortunately, further research suggests that we're failing these young people, and we're failing them quite a lot, so much so that they could be considered disadvantaged when it comes to access in healthcare. There are a few key papers because, you know, the NHS and the government has picked up on this, and more interest is being invested because of the apparent failures. And particularly, there was a fair damning report by the CQC in 2014 that highlighted fragmented services, abrupt, unplanned, lack of education for healthcare professionals, no clear outcomes, communication was failing, not enough funding. It was pretty sour reading, but there were some interesting points there too. And a few years later, NICE guidelines, produced some guidelines with regards to transitional services, and importantly, some main overarching key principles. So here you can see some of them. Throughout the guidelines, it reiterates the importance of involving young people and their carers in the delivery of their care. And also not only in the actual care, but also producing, co-producing policies, interventions, and assessing those with them. Transition, it's really important that this is developmentally appropriate, taking into account a young person's maturity, cognitive ability, psychological status, clinical needs, social and personal circumstances, etc. We must ensure that transition support is available, and that might not necessarily be limited to their healthcare professionals or their family. It could extend beyond that, so charities, support groups, etc. It's imperative, but in essence, it is in all care really that we use a person-centered approach. We need to treat that young person as an equal partner when it comes to decision making, so we can build relationships and, of course, autonomy and confidence in that young person. And again, lots more things to consider when it comes to patient-centered approach. Prescriptively, they say a transition plan should be created every year for a young person, but that could be more frequent depending on that individual. And of course, as healthcare professionals and managers of service, we need to ensure that all is in place, including education, in order to deliver this care. So time and time again, I get asked, why not replicate congenital heart disease transition? It's been around for a long time. It absolutely works. And probably in your ICC services, maybe CHD transition nurses carry out your transitional care. But time and time again, I will go back to them and say, because there are disease-specific factors in ICCs, and I'm sure I don't need to argue the toss in this forum, particularly because we know that the disease process can increase, or there can be a hot phase during adolescence. I think I've just ticked my phenotype remit there. We know that some of the young people in our services get diagnosed later on in life, so they haven't been born with a condition, they haven't grown up coming in and out of hospital, so this may be a new thing for them. There is a psychological impact of being at risk that CHD patients may not have in terms of developing a condition. They may also have previously experienced a cardiac arrest. We also know about our patients is that feeling well is not an indicator, so it can affect compliance and adherence. For me, probably one of the most important factors, though, and differentials between CHD and ICC in terms of transition, is that a lot of our young patients may have family members that also have an ICC or the same condition, or they might be at risk of that same condition. And that may be a good thing in terms of them learning healthy health behaviours, but it can also be quite a detrimental thing if perhaps that family member isn't managing or coping that well with their condition, or they're having a particularly tough time. And of course, there's a psychological burden of having an ICC and all that is encompassed within that. Now, because of this, the ICC nursing team back in 2005 decided to do an evaluation and look at the patient experiences of those young people transitioning through our service. At that point, transition was being dealt with by the congenital heart disease team. One of the nurses, Rachel Mackay, did a really brilliant project looking at this, and as a result was able to co-design a formalised ICC nurse-led transition service. And it's not by coincidence that I'm talking about transition today. Most transition services, be it cardiac, diabetes, lung, are often led or delivered by nurses. And this is what we came up with. And actually, it's been reviewed another time, I think back 2017, 2018. So it's been tweaked since its envision from when we first formalised, and it has been tweaked a little bit, and also to incorporate some of the changes of the last year. So our patients can expect to receive ad hoc nurse-led consultations in all of our consultant-led clinics, and that's anyone aged between the age of 12 and 22. Once a month, we have a dedicated nurse-led adolescent virtual clinic for 14 to 19-year-olds, and that involves other healthcare professionals. Up until recently, that was face-to-face and was considered a day case appointment where they would come in, speak to the nurse, speak to the doctor, and then there would be stations in different rooms where they could speak to a pharmacist, maybe a pacing technician or a clinical psychologist. And now we involve the genetic counsellors in that too. All of our patients have documented care plans or plans of care. We have a monitored email address, dedicated email address. We obviously have telephones that they can contact us on. We have a presence in outpatients and inpatients. We have dedicated patient literature. And we also have a really amazing annual ICC transition patient day. And I'll talk a little bit more about that in a moment. But in order to support this, there are other components. We have regular meetings. We've now developed a new complex ICC transition handover that we involve psychologists and safeguarding in, and we use a pro forma for that. And that's working really, really well for some of our really tricky patients. We now have a presence in the Trust Transition Steering Group, so we can be involved in policy making, learning, and making sure that we're in line with national benchmarks. We obviously have links to great charities, including the Brompton Fountain at the Royal Brompton Hospital. That gives us a lot of support. And we also, like anything else, approach this in an MDT fashion. And we regularly audit what we're doing. And now actually just engaging in some research with respect to this with our colleagues at Guy's and St Thomas's, Evelina, and King's College London. So here you can see an example of one of the plans. So this is a letter following a consultation with a young man. And this again emphasises why phenotype really isn't less important. This is a 20-year-old who's ready to start his master's, but still in our transition services, because he's struggling with the idea of what his condition is and what it means for him. He's engaged, but does struggle a little bit. Whereas his sister has a much more severe phenotype, younger, and is transitioned with little problems into the adult services. This also forms a plan, and as you can see there, I don't know if you can see it that well, there are goals for the next transition appointment. Here are a few pictures from our ICC transition day. The lovely nurses at the bottom there on the right, Lucy, Louise and Emma, who were the steering group behind this amazing day. The last one was in 2019. Obviously, we couldn't do it last year, but we're looking to plan another event this year. So, digital care. NHS England, well, COVID has done what NHS England couldn't do and thrust upon us digital care. There was a plan for all outpatient appointments to be conducted remotely by up to 25%, but we know that we're probably doing a lot more than that. I know certainly at the Royal Brompton, within the ICC service, it's looking more towards 70 to 80% currently, and probably going to increase. And when it comes to digital care in young people, we like to think that they're all tech savvy and ready to chomping at the bit to engage in remote and virtual appointments. But actually, that might not necessarily be the case. And there are some communities within healthcare that do recommend a bit of air of caution. The Young People's Health and Special Interest Group issued a joint statement about virtual consultations for young people between the age of 10 and 25 with the Royal College of General Practitioners and the RCPCH. And they said there are 4 key things that we should be careful of, and that's access, confidentiality, quality of consultation, and safeguarding. Access, we know that there are children living in poverty and might not necessarily have the access to Wi-Fi or devices. There are learning disabilities, auditory and visual impairments. English may not be their first language. Confidentiality, it's easier to manage. Parents not coming into consultation rooms when they're in clinic, whereas at home, that might be a bit more difficult to manage. They argue that quality of consultations might be affected due to technical issues, barriers with building trust. And that could be debatable. It depends where you sit, where your position is on this. But also, they seem to think that there are lots of reports that suggest this is not what young people want. And actually, anecdotally, well, not anecdotally, we carried out a focus group only a month ago asking this very question of young people. And they did come back and say actually made them nervous. They felt safer coming into the hospital and having their appointments. They felt more awkward doing it virtually. And one person even said that she was probably more likely to tell porkies virtually because she would felt put on the spot, camera blaring in her face when asked the question, whereas in a room, she could divert her eyes, look away and fiddle, and that would be her cue as, I haven't done that, what you've asked me to do. And then there's safeguarding. Safeguarding comes up not just with young people, but with vulnerable adults too. The fear is that they might be overheard. We might be missing non-verbal cues. So the recommendation there is that we have a very low threshold for face-to-face consultations if there are any concerns.
Bethan, just to let you know, we're at the end of the 15 minutes. If you could possibly tie up.
Sure, of course. So just a few future considerations. So staff training and education, whether we add transition competencies into nurse competency frameworks. UK, they believe that the problems with transition in the UK is because it's not seen as a speciality and there's no formal training, unlike other European countries, the US, Canada and Australia. So there needs to be investment with that. We need to continue auditing and measuring what we're doing. And then, of course, from that comes benchmarks. There are no benchmarks currently when it comes to ICC transition, but this is something that we're hoping to tackle with our most current research that we're taking place. And then finally, this is an important age group, but we need to think about the age 22 to 30-year-olds as well, because we can see similarities in this group and the different problems that that age group can encounter when it comes to ICCs. So I'm rattling through. So to conclude, I hope you know that now that transition could be seen as a speciality in itself and should be treated as such, and that when it's done well, it can be brilliant. It can improve clinical outcomes and the long-term quality of life. I hope that I've been able to argue that dedicated ICC transition should be implemented, and that more research into patient experience is needed and ongoing audit. And that primarily investment in developing in healthcare professional education strategies should be produced in order to make sure that these services are sustainable. Anyway, many thanks and sorry for running over.
Thanks, Bethan, no problem. I think we'll just eat a bit more into the Q&A session at the end, give people more time to think. That was a really excellent presentation. I'm now going to ask